right, welcome everyone. I can say good afternoon now. I have that it's noon on my clock. My name is Chelsea Byers, and I am happy to welcome you all to our third session of our Springtime Science series. Today, we are going to have a wonderful speaker with us. This is her second round, I believe. But first, let's talk about some housekeeping things. If you are seeking CEUs, we are going to put a link in the chat box, and this is the way you can check in so we know that you are here to get CEU credits. And the second link is if you have not paid for CEUs, make sure you go and check out the second link because the CEUs do cost. So if you have not paid for CEUs, you can go to the second link and register and pay for those CEUs. So again, the first link is to sign in. So you do need to sign in to let us know that you're here. And the second link is if you have not paid for the CEUs. And this is a collaboration between Illinois Extension and the Interdisciplinary Health Sciences Institute. And we are happy to have you for our ongoing community seminar series. Also, we will be launching a poll. This poll is just to collect some basic information from our participants. Once you fill it out, feel free to minimize it off of your screen. The poll is voluntary, but we do use this information to turn into some of our funders. So we would appreciate that if you would fill it out. We do try to reach a variety of people, so it does help us turn in that information. If you have any questions during today's program, please put them in the chat box. I will be monitoring the chat box of your questions. We will kind of stop at certain points to ask those questions. So please don't feel like I'm ignoring you if we don't ask them right away, but we will have kind of a set time to ask those questions of our speaker kind of in the middle and again at the end of the session. Now, without further ado, I'd like to introduce our speaker for this series, Sneha Das. She is a fifth-year PhD student in microbiology at the University of Illinois, Urbana-Champaign. And I'm going to pass it on to her and let her introduce herself a little bit further. Thank you for joining us, and take it away.
Well, good afternoon, everyone, and thank you, Chelsea, for introducing me. So as she mentioned, I'm in my fifth year of PhD in the Department of Microbiology. And prior to coming to the US, I finished my undergraduate and master's degrees in microbiology as well from India. I currently study DNA damage and repair in a bacteria called E. coli. And outside of lab in my free time, I enjoy traveling, and I am a national park enthusiast. And on my slide, you can see some of the pictures from my recent travels. So before we get into the patient versus pathogen aspect of our discussion, I would like to tell everyone that we live in a very microbial world. In fact, there are more microbes in the human body than there are stars in the Milky Way. About 10 to 100 trillion microbes live in or on us, and they form what we call is the human microbiome or the human microbiota. There are 1.3 times more microbial cells on the human body than human cells. So indeed, we are more microbial than we think. And our microbiomes are unique, much like our fingerprint. And our microbiome also keeps us healthy. And in many cases, they prevent the bad or so-called pathogenic or disease-causing bacteria from growing. So I would like to emphasize here that not all microbes are pathogenic. It's only a subset of microbes which are disease causing that we call as pathogens. So I have an audience engagement question here. So have you ever were you ever prescribed an antibiotic when you visited the doctor? And you can participate in the poll by answering a yes or no question. Do we have some results? Like I can't see the poll on my screen. Yes. Most of our audience, 92% of you are saying yes. And that's not surprising. As for me, I had to take antibiotics several times in my life, mostly when I was having respiratory symptoms like cough or cold, or stomach issues like diarrhea. Um, so it is not surprising that antibiotics are prescribed as often as they are, because they are important. A survey conducted in 2015 found that about 270 million antibiotic prescriptions are written in the US every year. So as many as 4 out of every 5 person that visits the doctor actually receives a prescription. And this is because antibiotics or antimicrobials are really important in modern medicine. So penicillin, many of you might have heard of it, was introduced in early 1942, 1941. And since then, if you look at the trend of deaths from infectious diseases, it has gone down drastically. And if we take a more specific example, say cystic fibrosis. So cystic fibrosis is a genetic disease that makes you more susceptible to frequent lung infections. And back in 1959, the median survival was only 6 months. But as more antibiotics were discovered and they were prescribed, median survival in 2010 became as approximately 40 years. So that's a drastic improvement. And no doubt, antibiotics and antimicrobials are important for us. So what are antimicrobials? Where antimicrobials, simply put, are medicines that prevent or treat infections from microorganisms. We can broadly classify pathogenic microorganisms into 4 groups, that is viruses, bacteria, fungi, and parasites. And we have antimicrobial compounds for each, like antivirals treat viruses, antibacterials or bacteria, antibiotics treat bacteria, and so on. So antimicrobials here is the broader term, while antibiotics is the subset that is used to treat bacterial infections more specifically. So today, as I discuss more about antimicrobial resistance, I may use the term antimicrobial and antibiotics interchangeably, or specifically give examples taking bacteria into account. But I would like to mention that resistance is a big problem across the spectrum. Like there is resistance to antivirals, antifungals, and antiparasitics as well. So now that we know that there are 4 types of microbes, I'll bring up a disease. It's going to be 4 diseases, and I want you to participate on what you think is going to be the pathogen that causes it. So our first one is common cold. What do you think? Well, most of our audience thinks common cold is caused by bacteria, viruses. Okay. Okay, great. Let's move on to the second one. What do you think about tuberculosis? Okay, most of our audience thinks it's a bacteria, but we have some which think it's a virus or fungi, but 54% of you are saying that it's a bacterial disease. What about ringworm? Okay, I see mostly parasites and fungi. And 68% of you are saying that it's a parasitic infection. And our last one is malaria. What do you think about? So I see a little bit of bacteria, parasites, Okay, so 39% of you are saying that it's a parasite and 35% of you are saying that it's a bacteria. So let's look at the results. So as many of you identified correctly, common cold is caused by a virus. In fact, it's the same family of virus that's causing COVID-19. And also many of you identified correctly that tuberculosis is caused by a bacteria. Interestingly, ringworm is actually caused by a fungi. So it's a fungal infection of the skin, while malaria is caused by a parasite called Plasmodium. So if we look at the top 10 infectious diseases that are affecting humans, we can see that they are caused by a wide variety of microbes. In fact, if we specifically look at meningitis, this infection can be caused by either a bacteria, virus, or fungus. And even for diarrheal diseases, like it can be either a bacterial or a viral infection. So we have these infectious diseases that can become life-threatening, and antimicrobials are really, really important for treating these infectious diseases. So where can we find antimicrobial compounds? Well, many of them actually occur in nature. Some of them are synthesized chemically in the lab. And oftentimes it might be naturally occurring, but then later on chemically modified in the lab to make it work better. So the microbes, they live in a very competitive environment and they are fighting for resources. So more often than not, microbes themselves secrete antimicrobial compounds to outcompete the ones living around it. And examples for this can be of the mold called penicillium, which is a fungus. It secretes antimicrobial compound, which we today know as penicillin, that inhibits bacteria. And then we have a bacteria called Streptomyces that secretes what we now know as antibiotic streptomycin, which inhibits other bacteria. So many of these antibiotics that we know today actually come from microbes themselves. We also see some antimicrobial properties in the food we eat, like allicin in garlic, curcumin in turmeric, and also compounds in honey is speculated to have antimicrobial properties. And another source of antimicrobials can be plants and herbs. So in Chinese traditional medicine, this herb called sweet wormwood has been used for a long time to treat intermittent fevers, which happen if you have a malaria infection. And we humans have been using antimicrobials without knowing them for a long, long time. So ancient Egyptians and Greeks actually used to treat wounds with moldy bread. And now we know that mold secretes antimicrobial compounds. Another interesting finding, like I was also surprised when I found this information, is that mummies, the Nubian mummies, have high levels of antibiotic tetracycline in their bodies. And scientists think that it is because they drank beer which was laced with antibiotics. And very recently, in 2015, many of you might have heard of it, Dr. Tu Yu, she won the Nobel Prize for discovery of anti-malarial drug artemisinin, which has actually been extracted from sweet wormwood that I mentioned in my last slide. And for years, she was looking at these traditional herbs and medicines to see if she can isolate a molecule that would work for malaria treatment. However, the very first instance of an antimicrobial compound discovery was done much before terms like antimicrobials or antibiotics was even coined. And it was Paul Ehrlich and Sahachiro Hata, and there was this organic compound that was synthesized in Ehrlich's lab called Salvarsan, and they tested it and found that this compound could inhibit the bacteria Treponema pallidum, which causes syphilis. And back then, Ehrlich called Salvarsan the magic bullet. And as you can see in the picture here, that the syphilis treatment kit back in those days was pretty elaborate. And Salvarsan worked well, but it also had a lot of nasty side effects. And it was soon replaced with a modified version called Neo-Salvarsan, which worked better. However, the first case of reported case of antibiotic discovery was actually made by Alex Fleming in 1928. And he was studying a bacteria called Staphylococcus. And he had gone on a holiday and he had forgotten to close his plates, bacterial culture plates. And when he returned, it looked something like this. Where you have a mold growing in one of the corners of the plate, and then you can see the bacterial colonies are white, but they are not growing around the area where the mold is growing. And hence he discovered penicillin that could inhibit bacterial growth. And in Fleming's own words, one sometimes finds what one is not looking for. And when I woke up just after dawn on September 28, 1928, I certainly didn't plan to revolutionize all medicine by discovering the world's first antibiotic or bacteria killer. But I suppose that is exactly what I did. So this was a serendipitous discovery that saved so many lives. But however, it was Florey and Chain who took penicillin from the lab and actually to the patients. And interestingly, the first large-scale production of penicillin took place very close to us in Peoria, Illinois, in the Northern Regional Research Laboratory. And penicillin went on to save many, many lives during World War II. And then in 1945, Fleming, Florey, and Chain were awarded the Nobel Prize for discovery of penicillin. Eventually, many, many more antibiotics were discovered between the 1930s and the 1990s. Many of these antibiotics or antimicrobials were bactericidal, that is, they killed the bacteria. You can see the ones here in dark green. And many of them were also bacteriostatic or bacteriostatic. That means they restricted the bacterial growth without killing them. So I have another audience engagement question. So for which of these medical procedures do you think antibiotics are necessary? So I can see responses are divided amongst all these options. It is a trick question. Actually, we need it for all of these procedures. Like many of the surgical procedures and chemotherapy that we have today wouldn't exist without antibiotics. And the reason for this is we don't just use antibiotics to treat infections, but we also use antibiotics to prevent infection. So if you were to have a surgery tomorrow, you would be prescribed antibiotics as prophylaxis. So without antibiotics working, we would not be able to have all these modern medical procedures, these surgeries, chemotherapy that we take for granted today.
Neha, I have a question that might fit in nicely here. So what do you take if you're allergic to penicillin?
So there are alternative medications, like there are alternative antibiotics that look different from penicillin, like are structurally different. So there are alternatives definitely for it.
Thank you.
And just to go back to the question, like I mentioned before, that since penicillin was discovered, we have had different classes of new antibiotics that have come up. So if you are allergic to penicillin, there are a wide variety of options that your doctor can prescribe to you. Okay. So now coming to the issue of antimicrobial resistance. So in fact, Fleming saw antimicrobial resistance occurring really early on. And in his Nobel lecture in 1945, he mentioned that one of the dangers that he feels is that an ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug, make them resistant. So even back then, he feared that antimicrobial resistance would occur, and that is the case that we see today. Oh. And the World Health Organization defines antimicrobial resistance as follows. That is, antimicrobial resistance occurs when bacteria, viruses, fungi, and parasites change over time and no longer respond to medicines, making infections harder to treat and increasing the risk of disease spread, severe illness, and death. And currently, scientists are most worried about the escape group of pathogens, that is the Enterococcus, Staphylococcus, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter species. And very correctly, as the pseudonym says, is that they escape antibiotics. And as many of you might have heard, of methicillin-resistant Staphylococcus aureus or MRSA, or even vancomycin-resistant Enterococcus or VRE. So they are problematic because they are resistant to some of the antibiotics that we have, and these antibiotic resistant strains can be very expensive to treat as well, and not just life-threatening. And if we look at this table from CDC, you can see that we have a list of antibiotics and when they were released, and then subsequently when resistant microbes were identified. And as you can see, for almost all of these antibiotics on this table, we have microbes that are resistant. And if we look at penicillin, you will see that the first instance of penicillin-resistant Staphylococcus aureus was identified in 1942, shortly after penicillin was introduced in the market for patient use. And if we can also here look at another pathogenic fungi called Candida, and you can see that it's resistant to amphotericin B, fluconazole, caspofungin, three very important antifungal drugs. So if you happen to have an infection from this pathogenic antifungal resistant Candida, it can be very difficult to treat. However, some antibiotics like azithromycin have been more successful. As you can see, there has been a significant delay from when it was introduced in 1980s to when the first resistant microbial strain was identified. But the main takeaway here is like, no matter how good an antibiotic or an antimicrobial compound is, the microbe will eventually become resistant. So most of these antimicrobial compounds, or specifically I'm taking bacteria as an example here, like the antibiotics, they target essential cellular processes, like they will target enzymes or important pathways for the bacteria. And in order to become antibiotic resistant on a molecular level, bacteria has strategies. The first option can be just developing a new cellular pathway instead. So if the antibiotic is targeting a pathway, it just finds another way to reroute and do the same thing. A second strategy can be changing the target itself. So if you have an antibiotic that targets a specific molecule or an enzyme in the cell, the bacteria just mutates it to look a little different such that the antibiotic no longer recognizes it. And the bacteria can also make enzymes that will degrade the antibiotic and so that it no longer works. So it can just simply destroy the antibiotic inside it. Another way could be just restricting the antibiotic from entering the cell by changing the pathway or the protein or just the cell wall structure of the cell and preventing the antibiotic from entering. And another strategy could be simply to get rid of the antibiotic even if it has entered the cell. And the bacteria uses efflux pumps or pumps that just flushes the antibiotic out even if it manages to get in. Now, all these changes are actually made in the DNA level. So we have mutations happening in the DNA that make these changes. So how does these antibiotic resistance trait spread from one bacteria to the other? Well, the most common method is if it's passed on from one generation to the other. That is when a mother cell divides into daughter cells. Now the daughter cell has the gene. And another second more interesting strategy is horizontal gene transfer. That is, you don't even have to be related to get the gene that is antibiotic resistant, and it happens through mobile genetic elements. So first, let us talk about the first mechanism, that is through natural evolution. So imagine that we have a population of bacteria that is susceptible to say antibiotic X. Now, as this population divides, one of the cell here, while dividing, randomly accumulates a mutation in its DNA such that it is now resistant to antibiotic X. And in the future, say now antibiotic X treatment is done on this population. So all the susceptible cells are going to die out. However, this lucky cell that acquired this random mutation is now going to survive. And as time passes, it will reproduce. And now suddenly we will have an antimicrobial resistant bacterial population. And this method is called natural evolution. And the second one is more interesting, called horizontal gene transfer. In this method, a bacteria like Staphylococcus can pass on its genetic material to a bacteria called Salmonella, say, for example, even though they are not related in any way. And they do this through mobile genetic elements. So what are mobile genetic elements? Well, they can be of three types, that is plasmids, transposons, and phages. So phages are bacteria that attack, phages are viruses that attack bacteria. Now, what these mobile genetic elements have in common is that they are not part of the normal chromosomal DNA, and they exist independently, and as the name suggests, can be passed on from one cell to the other without any reproduction being involved. So how does that happen? Well, one strategy is transduction, which involves a phage. So here you have a bacterial cell, and imagine that you have a mobile genetic element. So when this phage infects this bacteria, it picks up this mobile genetic element, and then when it goes on and infects the next cell, it injects that DNA into the second bacterial cell, which now happens to have this mobile genetic element, which has resistance. A second method can be conjugation. Here, two very different microbial cells can form a tube-like connection, which we call the conjugation tube. And as it is formed, this mobile genetic element can just pass on from one bacteria to the other. And one, say, maybe Salmonella, and the other is Staphylococcus. So they're completely unrelated. And a third method can be transformation, where you have random DNA sequences in the environment. They can be there because some cell has died and now its DNA is out in the environment. And this other cell now picks up random sequences of DNA by transformation process, and one of them could happen to have an antibiotic resistance gene. So now that we know a little bit about how bacteria become resistant, let's shift gears a little bit to antibiotic use. So where do you think most in which of these places would you think that antibiotics are used the most? Okay. Okay, so 36%, okay, so 35% of you think that it's intensive care units. And honestly, it's not surprising. But in fact, the answer is livestock industry, and 30% of you have identified it correctly. So the surprising thing is, of all the antimicrobial compounds that are out in the market, at 70% of them are actually consumed by animals, and humans only use 30% of it. And it is a little problematic because most of the antibiotics used by the livestock industry is for non-therapeutic purposes. Like, it's not given to the livestock to treat any infection, but simply to make it grow faster. So why do we care about this? So of the 41 FDA approved drugs for use in livestock, actually 31 of them are considered to be medically important for human use. And what we fear is that if we feed these antibiotics to the livestock, that they will develop some antibiotic resistant strains in their body. And then it can pass on into our environment through animal excrements or through food or even direct contact with humans. And hence antimicrobial resistance strains can spread. So while livestock is one method by which these antimicrobial resistant bugs can enter our environment, the other route is through us humans. So say a patient has been prescribed an antibiotic, and for whatever reason, they happen to develop some drug-resistant bacteria. Now, if they are sick, or they go to a clinic or a hospital which doesn't have the best hygienic environment, then they can spread this resistant bug to other patients or in that facility. And it can also happen by other mechanisms due to poor hygiene and poor sanitation. So I would like to point out here that it's not the human or the patient who is resistant. It is the bacteria in the human body or the pathogen that is infecting the human that is resistant to the antibiotic. So it's important to make this distinction that antibiotic resistance is actually happening in the microbe, and you are resistant to the treatment because you're infected by this microorganism. So in the same lines, like, what do you think about antibiotic prescriptions? Like, how much of it is unnecessary? Okay. So 73% of you say that 75% of antibiotic use is unnecessary. Well, you are a little off. So according to CDC, it's just 30 to 50%. Well, it's not surprising because in some developing countries, like I'm from India, and I know that antibiotic prescriptions in India are frequently given out. So in some countries, this number, as you say, can go up to as high as 75%. But because of awareness, I think the numbers have come down. And the most recent numbers are somewhere around 30 to 50, but it can be higher in places where there is less awareness among healthcare professionals about when to prescribe antibiotics or not. However, most of this confusion actually comes from because we don't know if the infection is bacterial or viral in nature. So say if a patient shows up to a clinic or to a doctor saying that they have symptoms of fever, cough, and cold. And while these symptoms can be caused by viral infections like flu or even COVID, but it can also be caused by bacterial infections like Streptococcus pneumoniae. So it's very hard for the doctor just by seeing a patient and seeing their symptoms to know if it's bacterial or viral. And the problem here is that many bacterial culture tests take a few days to come back. And that makes the doctors kind of wary of whether it's bacterial or viral. And many a times they prescribe antibiotics to be on the safe side. While we were having this pandemic, antibiotic use went up around the world significantly. And it is because most doctors fear that after you have had a viral infection like COVID, that you might have what they call is a secondary bacterial infection in your lungs, like pneumonia. So just to be on the safe side, many of them prescribe antibiotics, but this is definitely an instance of antibiotic overuse. So a way around this can be developing rapid diagnostics. And I think we ourselves experienced it at the university. We had this saliva test for COVID, and the results were back in just a few hours. So say if you have these symptoms and the doctor thinks that it's viral or not, and you take the test, and if you're positive, then you know it's a viral infection and you don't need antibiotics. So as of now, antimicrobial resistant infections kill as many as 1.2 million people. And in the year 2050, this number can go as high as 10 million, which will surpass both cancer and diabetes. And if this problem is not tackled, one person can die every 3 seconds. So this is a huge, huge toll. And Asian and African countries are worst affected by AMR infection deaths. And as you can see here, that AMR infections are also more expensive to treat. And currently, World Health Organization considers AMR as one of the biggest threats to global health, food security, and development. So what do you think would be the best strategy that we can use to tackle antimicrobial resistance? So if we can have the poll. Oh, sorry. Oh, cannot go back. Yep. So do we have the poll up? I cannot see my screen. Oh, okay. Would any of you like to enter the answers or speak up, or like we don't have a poll for this?
Why don't we just use the chat box?
Yeah, the chat box to just say what you feel might be the best strategy. All public awareness, surveillance, all of them seem like good idea. We see a lot of alls. And in fact, you are correct. We can use all these strategies, and I'm going to discuss one of them, discuss them one by one. And the first can be like antimicrobial use. And if we look at this graph here, back in 2000, France was prescribing the highest number of antibiotics to its patients. And then a year later, it also had the highest instances of antimicrobial resistance in its bacterial antibiotic resistant bacteria. On the other hand, Netherlands was prescribing the least and also had the least cases of AMR resistance. So there is definitely a correlation, and we can be sure that if we use antimicrobials more cautiously, then cases of antimicrobial resistance would go down. And also, it will be very good if we can differentiate between bacterial and viral infections by diagnostic tests, because antibiotics specifically work for bacteria and they don't work for viruses. And there are many antiviral drugs as well. Like you may know of some of them for flu, and now we have medicines for COVID. But I think the takeaway here should be antibiotics don't work on viruses and should not be prescribed for viral infections. Again, surveillance can be a great strategy. Like we can look for new and upcoming antimicrobial strains at a local level, nationally, and also globally, and pass this information around so that we know which antibiotics are not working. But again, for this to be successful, there needs to be huge like a really good cooperation and coordination on all these levels. And we also need public policies in place for this to be an effective strategy for tackling AMR. And the third strategy can be hygiene. And it has been seen with hospital workers and healthcare professionals that if they just wash their hands more often, then the patients are less susceptible to infections. They get less infections and hence need less antibiotics. And we ourselves observed this during the pandemic. We were washing our hands, and hand washing and good hygiene definitely works in preventing infections and hence reducing antibiotic use. Another strategy can be developing alternatives to antibiotics. And as many of you know that we have this pneumococcal vaccine for pneumonia, which is prescribed mostly to elderly and immunocompromised patients during the flu season. However, studies predict that if we were to vaccinate our whole population with this vaccine, then the use of antibiotics for pneumonia cases would go down by 47%. So that's a good number. So there is research ongoing to and they are trying to develop vaccines for specific bacterial infections. And we saw vaccines for COVID work really well as well. And there can be alternative strategies as well. Like if we are talking about specifically bacteria, then scientists are considering phage therapy. So you have this phage, which is a virus that attacks the bacteria and kills it. So that can work. Or you can have enzymes that kind of degrade the bacterial cell wall or just compromise the bacteria and kill it. However, all these are under development, and we may see these alternative therapeutics come up in the near future. And what about new antimicrobials? Like just make new ones? Well, as you can see from the time when penicillin was discovered, there was a huge boom in antibiotic discovery, and till the 1990s, we had several new antibiotics that had come up. But since 1990 till now, we have what is called the discovery void. And it is because discovering antibiotics is no longer profitable, and there is very little investment in antibiotic discovery. And as you can see from the graph here, that discovering an antibiotic is mostly unprofitable. And in fact, it might even you might even be at a loss if you spend the money in antibiotic discovery. And very sadly, like very few of these big pharmaceuticals are discovering antibiotics these days, because if you develop a drug for a more chronic condition like diabetes, then the patient has to take this drug regularly. But however, if you were to develop a drug for an acute condition like an infectious disease, then the patient might only need it once in their lifetime. So that's a problem. And the second big issue is that even if you do find an antimicrobial, it will become the bacteria will become resistant in times to come. So there should be policies in place to incentivize companies to develop new antibiotics, and most of the research going on antibiotic discovery are now in academic labs or really small or medium-sized biotechs. However, new funds are being set up to kind of incentivize the process for big pharma, for them to participate in antibiotic discovery, because we really need new antibiotics if we are to tackle antimicrobial resistance. And one of the best strategies, as many of you said, is public awareness. So I have some questions for you. Can answer them with yes or no. So what would you do under these circumstances? Like, you're feeling better, should you save some of your antibiotic for later? I see most of you say no, and that's a good sign. So you should finish your full prescription of antibiotics. What about the second situation? You just, oh, sorry. Anyway, I had the answer up for you. But say if you're just starting to get unwell and your friend says that they have some leftover antibiotics, and many of you and all of you said no, and that's the right thing to do. Never take antibiotics from someone who's not a healthcare professional, and do not self-diagnose yourself. And your doctor says it's flu, and you see some green snot, like, and you feel terrible. Do you trust them or do you take antibiotics? Again, I see a lot of no's, and that's right, because antibiotics don't work for viral infection. There are new antiviral drugs, but antibiotics are specifically for bacteria. So you don't need them for viral infection. So in today's talk, we saw that AMR is a serious problem, and it kills over 1.2 million people around the world every year. And it's only going to get worse if we don't do anything about it. And what causes antimicrobial resistance? It can be because antimicrobials are overprescribed. Often patients don't finish their treatment. We also saw that there is overuse in the livestock industry. It can spread in hospitals or clinics where there is poor infection control. It can spread in where there is lack of hygiene or poor sanitation. And unfortunately, we don't have new antibiotics being developed since the 1990s. And we also saw that antimicrobial resistant drugs can spread from livestock or even from humans into our environment. And once it's in our environment, we are all going to be affected by it. And as we also discussed, it's not a simple answer or a simple solution. We need policymakers to implement policies in place and also to improve surveillance and cooperation between nations so that we alert each other if there is antimicrobial resistance coming up. We need pharmaceutical companies to invest in antimicrobial discovery, even if it's not apparently profitable for them. And we do need the livestock industry and even for healthcare workers to reduce the antibiotic use, because the less we use antibiotics, the better we would tackle this problem of antimicrobial resistance. And as we the people, we need to do our part as well. So what can we do? So only take antibiotics if you're prescribed by a healthcare professional. And then if you're given an antibiotic, finish the full prescription, even if you feel better and even if you think that you don't need them. Because if you underdose and if you don't take the full prescription, you're more likely to have bacteria that will develop resistance. Also, never save your antibiotics and never take them later if you feel like you have same symptoms. And like we also talked about, like many of the symptoms can be both viral or bacterial. So you don't know which one it is, and it's best to leave it up to a medical professional whether they should prescribe you an antibiotic or not. And never share it with family or friends. And as we all experienced during COVID, during the pandemic, that we can do our part. That is, if you wash your hands and if you stay away from other people when you're sick and don't come in contact, and if you take your vaccines, like we can overcome this problem. So that brings us to the end of the presentation, and I'm open to answering questions or discussions, and you can provide your feedback using this QR code.
All right. You can find your reactions button and show your appreciation for Sneha's program by giving her some claps or some thumbs up, because she did a fabulous job. I learned a lot. You can use your smartphone and hold it up and take a picture of that square, and it'll take you to our evaluation link. Otherwise, you can click on the evaluation link in the chat box, but we do have a question that came in. It says, does having a strong immune system help fight this, help the antimicrobial resistance?
Yes, I would say the best approach for any kind of infection is if your body makes antibodies and fights them. Like there's nothing better than your own infection. But often we are not very successful in this because, as you saw from the graph of penicillin, like before penicillin, people were dying from infection. So often what happens is, if your body has seen the infection before, that it can respond very quickly the second time around. However, say you have not had an infection, often there isn't enough time for your body to fight it. And that's why in many cases we need antibiotics. So if you have a strong immune system and if you have a strong immune response, there's nothing as good as that. But often it doesn't happen quickly enough for you to like fight off the bacteria or the virus or whatever is infecting you. And then you need these antimicrobials to help you.
All right, other questions? Does anybody else have any other questions? We had two good questions in there. I didn't see any other questions, so if I missed your question, feel free to rewrite it in the chat box. We have a lot of thank yous, good information, very interesting, excellent webinar, very informative topic. So just a lot of praise for the session.
Thank you.
If you want to flip it to the next slide, we can show them what's coming up next week. Next week, we have Erica Noel, and she's going to talk about Information overload, how being too informed is hurting the health of our world. And so that is coming up for our 4th session of our Springtime Science series. And we did get another question in. She says, I have a cold. Does that mean my immune system is weak?
Not necessarily. I mean, we get sick all the time. Like it's like if you have, I would say what happens is we all get sick all the time. So say if you have a viral infection for the first time, then your body is seeing this infection for the very first time and doesn't necessarily know what to do with it. And it doesn't have antibodies. So it uses something called innate immune system. Like that's a very general response to fight off this infection. And while it's doing so, your body kind of breaks up this pathogen into small parts and then eventually starts making antibodies for, say, in this case, it's a virus. It starts making up these antibodies. Now, say if you have again this same virus coming back and infecting you the second time around, then you already have these antibodies ready, right? And then your body kind of gets rid of this pathogen much quicker than it did the first time around. So getting sick, like usually people get sick once or twice a year. If it's more often than that, then maybe you're immunocompromised, then maybe discuss it with your doctor, but it's not uncommon for people to get sick.
And then oh, sorry.
Yeah, sorry.
We do have another question. Is there a critical period for children to be exposed to certain bacteria to help develop their immune systems?
Okay, so I would like to break up this question into 2 parts. So developing the immune system, like we as humans, like we have very little control over how to develop it. So there's nothing that we can do intentionally to make our like immune system stronger. Yes, we can eat healthy, we can exercise and do everything that we can in our part to keep ourselves healthy, but how much that impacts our immune system is not necessarily, I'm not sure if there's a necessary correlation like scientifically established. So much of this immune development like happens in a very passive manner. And if you have children, you might have noticed that they get very sick in the initial few years, and then they don't get sick as frequently as they are older. So that's the time when they are developing their immune system per se. And then the second question comes up about critical period of infection. So there's always something called an incubation time. So if you get a virus or a bacteria today, you might not be immediately sick the other day. So it takes a while for this pathogen to replicate in your body before you actually start showing any symptoms of it. And this period can, incubation period is different for different pathogens, which can range from days and in some cases to even months. And for some cases, it might even be years. An example for this can be if you have chicken pox, that virus can actually latently stick around in your body for a while and then come back and give you shingles later on. So this critical or incubation period can be different. Does that answer your question?
She says, yes, that makes sense. Thank you.
Okay.
Yeah. Just to be mindful of everybody's time, we're about to the end. So I want to say thank you to our speaker and to everybody who joined us today. It could be a interesting weather day for most of us out there. The weather looks like it's going to be pretty widespread. So we hope everybody is safe and is aware of the weather today. So thank you everybody for joining us today. We hope you all can join us next week to hear Erica. And thank you again for joining our community seminar series, and stay well and stay safe. All right. Thank you, everybody.
Thank you.